So, good morning, everyone. I am Glazielli. So I will host the webinar with Dr. Mayson today. So it's a pleasure and for us to have him here with us. And Dr. Mayson is an assistant professor at University of Manitoba in Canada and cardiopulmonary physiotherapist, specialized in respiratory physiology, mechanical ventilation, and ARDS. Dr. Mayson, he finished his PhD at University of São Paulo with a collaboration with Dra. Juliana Ferreira and Dr. Marcelo Amato. And after, he went to Canada to do his fellowship at University of Toronto, working with Dr. Laurent Brochat. And in the past years, Dr. Mayson is publishing papers with a very, very interesting topics in mechanical ventilation using EIT with asynchrony. And for us, it's really, really a pleasure to have him here. So thank you a lot, Mayson, for your time. And we will open the Q&A for later. So please, everyone, if you have any question, write in the Q&A and then we can discuss this later. And Mayson, if you are ready.
Okay, so I'm gonna share my screen. So just let me know if everything is okay. Can you see my screen?
Yes, we can
Okay.
see that. Thank you.
So,
the time is yours.
thank you. Thank you very much, Liz, for the nice introduction. Thank you for the invitation. It's a pleasure for me to be here talking about these two topics that I really like. That's patient-ventilator asynchrony and electrical impedance tomography. So I brought some stuff for us to think about. It's a very broad topic. There are a lot of points to discuss. So the idea is just to show you a little bit, and if you have time, we discuss some at the end. But yeah, it's to think about how we could improve the management of patients with patient-ventilator asynchrony. So just to let you know, we're going to start talking a little bit about the clinical presentation of patient-ventilator asynchrony. Then what would be the impact, the clinical impact of a patient presenting asynchrony? And I hope to discuss with you what is the current management for patients with patient-ventilator asynchrony and how the use of EIT could improve patients' outcomes. So let's start talking about a little bit about patient-ventilator asynchrony in general and how is the clinical presentation. So mechanical ventilation is a life-saving support. It's used for millions of patients around the world. And it's one of the main reasons why a patient is admitted to the ICU. However, it may also be associated with worse clinical outcomes and result in both lung and respiratory muscles injury, which is understandable because we are looking at two very complex systems. So on one side, we have the ventilator with a very complex system, as I said, and on the other side, we have the patient. Okay, with several systems that we need to look at them and the interaction between them to really offer a good support for a patient with a lung injury in general. However, there are still several challenges managing patients in mechanical ventilation, and one of them, for sure, one of the key factors is how is the interaction between the patient and the ventilator. So every time that we have a mismatch between the patient's respiratory demand and the effort and what we set in the ventilator, how the gas is being delivered, we are facing asynchrony. However, most of the time, we only notice in clinical practice, like this most like severe cases where we say that the patient is fighting the ventilator. And this is not what patient-ventilator asynchrony is. This is one, I would say, last stage of patient-ventilator asynchrony when it's really clear. But if you have noticed just at this point, you definitely have missed something before that. And that's what we're going to discuss today. So how prevalent is it? When does it happen? So there are, in the past few decades, there has been a couple of studies that are studying patient-ventilator asynchrony. I just brought here a couple of them from 1995 to 2020. And we can see that up to all patients, like it's some of those studies have reported that all patients on mechanical ventilation at some point will have patient ventilator asynchrony. Okay, so as low as 11% to as high as 100% of the patients may have patient ventilator asynchrony. And why is this number so variable? Uh, well, there are possible a lot of factors. The types of asynchrony, as I'm gonna briefly show you in a minute, the duration of the observation for how long I am assessing patient ventilator synchrony, because we know you're really busy looking at several things in the ICU. For how long do I actually stop to actively look for patient ventilator synchrony? This is going to impact on how much I see of asynchrony, and also the methods that we are using to assess it. Another one of the measurements that we have been using in research to measure asynchrony is what we call asynchrony index. That's like, in a simple way, is the percentage of breaths with any type of patient ventilator asynchrony. Okay, so and again, this is another number that changes a lot in studies. It can go as high as 45%. So 45% of the breaths would have some type of asynchrony. However, studies that have looked at the entire period of mechanical ventilation and looking at several types of asynchrony has shown that around 3 to 5% of breaths will have some type of asynchrony at some point. So those are high, okay? So thinking about that, all patients will have asynchrony at some point, and up to 5% of these breaths will have some type of asynchrony. And okay, as I said, there are several factors that may influence, and one of them is definitely the types of asynchrony. Unfortunately, to make our life harder in a clinical practice, there are several types of asynchrony. Asynchrony is like a really broad term, but we have several types of conditions that we are talking about. So a way that I liked looking at it, it's thinking about the respiratory cycle, okay? The phases of the respiratory cycle. The trigger, the inspiratory phase, the cycling, and the expiratory phase. So let's think about what would be a normal breath, and what could go wrong with that. So if you look at this respiratory cycle, a normal, we have some types of asynchrony that occur at the beginning of the inspiration, the triggering phase. Okay, so we have ineffective effort. I'm going to talk a little bit about all of them. Again, it's not the main goal of the webinar, but I'm going to try to cover a little bit about them just for us to understand how it's important and what do we need to know to manage. So we have some types of asynchrony that occur at the beginning of the cycle that we call like triggering asynchrony. We have other types of asynchronies that occur during the inspiratory phase, and we call them inspiratory flow asynchronies. And we have some types of asynchronies that are related to the transition between inspiratory and expiratory phase, and we call them cycling asynchronies. This is one type of nomenclature that we are using. If you go deep in the literature, you're going to see that there are several other ways that people have been naming them. So that's why instead of like going deep in the names, I'm going to let you know what is happening in each of these types of asynchrony. I think that's important. More than the name, it's to understand what is going on. So to start with the asynchronies that occur during the triggering phase. So we have four types of asynchrony that we usually refer to. One of the most common is ineffective effort. And as the name says, it's a patient's effort that it wasn't noticed by the ventilator. So the patient did an effort, it was maybe too small or your trigger was too high. But you can see, for example, here in a flow waveform, that the flow is increasing during expiration, like disproportionately to what was increasing before, indicating that the flow was going in the direction of the patient, and we saw a drop in the pressure. So this was an inspiratory effort, and it was not followed by a breath. Okay, so this was an ineffective effort. It's one type of asynchrony. What's going on? What's going to happen if the patient keeps like having this missed breath? The other one is double triggering or double cycling, as some authors would prefer to say. This is a very common and I think maybe one of the most dangerous types of asynchrony, like potential harmful types of asynchrony. So initially when we thought about double triggering, when it was defined, it was like two cycles that are separated by a very short expiratory time. Okay, so we thought that, okay, this and the first studies show that when we would observe this, we would have an inspiratory effort. You can see here the esophageal pressure indicating the patient inspiratory effort. It was so high that even after the first breath, the patient was still having the inspiratory effort, and it ended up triggering another breath. So we would have these two inspiratory cycles here. Okay, so two inspiratory phases very close to each other. So the patient didn't have time to exhale the volume completely, and the ventilator was already delivering another breath. So we had this double triggering or double cycling. So this double cycling nomenclature came because actually it's not always what happened is one effort that is too strong that triggered two breaths. Sometimes the first breath was triggered by the ventilator and only the second one was triggered by the patient. So this is what we call reverse triggering. So reverse triggering this is a more recent type of asynchrony that we have been only lately really paying attention to that. But it would be an inspiratory effort that starts pretty much after controlled breath. So the ventilator delivers the gas, and then something happened. We hypothesize that maybe a stimulation to the patient's inspiratory drive, and the patient starts like breathing. So if you look here at the flow waveforms, for example, so the first breath was controlled. So the ventilator sent a delivery of gas that was set. And then the patient started like having an effort in the middle of inspiration, and we still observe it after the end of inspiration. Some authors refer to this type of asynchrony as an interment of the inspiratory drive, because we have this controlled breath, and then the patient starts like having an inspiratory effort a little bit later after that. There are several ways that this type of asynchrony may present, but what's important to keep in mind is that sometimes if the effort is too strong, we may have these two breaths as the last one that we see here in the waveforms that are pretty close to each other. And again, we have this double cycling. So that's why we have double triggering when the patient is triggering both breaths. And we have reverse triggering when the patient is triggering only the second one. And we can refer to both of them as a double triggering. And they will ended up with a breath stacking. That's what we call when the tidal volume is summed between the first and the second breath. So these are very important types of asynchrony. Imagine that we may be delivering to the patient up to 2 times the tidal volume that you have set, and we know that high tidal volume is not good for patients with severe acute lung injury. And the last one is the auto-triggering. So it's a breath that was delivered, but it was not followed by a patient effort. It was maybe a leak in the circuit or the heart rate, some instability in the chest that auto-triggered a breath. So just two other options, two other types of asynchrony. We have the inspiratory flow asynchronies. So the inspiratory flow, it can be either excessive, so above what the patients want. So usually what we see is this overshoot at the beginning of the inspiration here. So the flow that we set is too much for what the patient needs. Or we may also have insufficient flow. So the patient demand is way higher than the flow that you set in the ventilator at that time point. And finally, the cycling asynchronies. So the cycling, the transition between inspiratory and expiratory times may be too short. So the patient would continue to do an effort, as we can see here in the first panel in the top. So at the end of the expiration, at the beginning of the inspiration, we still see an increasing flow that indicates that the patient is doing an effort. Or the cycling may be delayed. So maybe the inspiratory time that was set in the ventilator is longer than the patient neurologic inspiratory time. So how we see it is usually with overshoot at the end of inspiration and the flow pressure. This usually indicates that the patient is actually at this time point is starting to use the expiratory muscles to actively breathe. So the pressure in the airways increase because the patient is doing an effort, an expiratory effort. So those are types of asynchrony, just for you to know that there are several, and it's important, like beyond the name of the asynchrony, it's important to understand what's going on so we can do something to try to adjust it, to manage it, to prevent, or to treat. Okay, so, but what is the clinical impact of all these types of asynchronies that I just briefly present to you? So this is a very important study in the field of patient-ventilator asynchrony, led by Dr. Lohan Brochard and Arno Chile, where they study patient-ventilator asynchrony during assisted mechanical ventilation. And they explored a little bit more this idea of this asynchrony index, so the percentage of breaths with asynchrony. And they also categorized patients with a high prevalence of asynchrony as having a synchrony index equal or greater than 10%. And what they observed was that these patients that had this high prevalence of asynchrony had a longer duration of mechanical ventilation. The number of days of mechanical ventilation was, the median was 7 in patients with low asynchrony index compared to 25 in patients with high asynchrony index during assisted ventilation. Okay, they also observed other impacts, including tracheostomy. And this was confirmed in subsequent studies, also showing most of the time that higher incidence, higher prevalence of asynchrony would be associated with an increase in the duration of mechanical ventilation. So what is the clinical impact? So, okay, so we know that it's associated with duration of mechanical ventilation, okay? But there are still several authors that question if asynchrony is just a marker of severity, okay? Well, we know now a couple of experimental studies have shown that patients with some types of asynchrony, for example, breath stacking, this double cycling with breath stacking may result in lung injury. Some types of asynchrony, for example, reverse triggering, depending on the magnitude of the effort, may result in muscle injury. And we know that if it reaches this stage here, the patient will have dyspnea. We have some studies that have also shown impact on sleep. Okay, so we have some direct impacts of asynchrony, okay, in terms of lung injury and muscle injury and the patient's comfort in general. But we also gonna have the indirect consequences of asynchrony. Because if we see a patient with asynchrony, unfortunately, what is done most of the time is to increase sedation. So let's just suppress the patient effort and do some sedation or just do neuromuscular blockade, blocking agents without thinking about what would be the consequences of that. And all of this may increase duration of mechanical ventilation and may impact mortality. So it's important to look at asynchrony. It's definitely it has potentially direct impact some types of asynchrony, and may also have indirect impact. However, this idea has been more so for the first years we were always thinking about, okay, synchrony is bad, the patient's not comfortable, let's do something about that. But what recently publications have shown that is maybe it's not always the case. Sometimes, like the patient's just like the sedation is we are just like reducing the sedation, the patient it's awakened. So that's good. That means that the patient is start breathing on their own. So there are potential scenarios, some types of asynchrony. We need to consider the effect of asynchrony on the lung injury, the level of effort, those kind of things. And in some scenarios, asynchrony may be good, may be a good signal. Another way to look at asynchrony is, this was one of the studies that we did there in Brazil, where we look at clusters of asynchrony. Okay, so periods of time in which we had a high incidence of asynchrony. And we looked specifically to double triggering for this study specifically. And we have two examples of patients here. So in the first panel, in the first graph, we have a patient that presents at some point of the ventilatory support, a higher incidence of double triggering. On the other hand, we had a patient that during several times presented a high incidence of double triggering. So we could categorize these patients in low duration and high duration of clusters at the end. And was very interesting to see that this was associated with survival of patients. We adjusted this for the duration of mechanical ventilation, of course, and for the severity of illness. And these patients that presented this high duration of this double triggering asynchrony. So here we were looking at the double triggering, what it's actually called, and at that time point also reverse triggering was included in the definition as we used an automatic software, and at that time point these two types of asynchronous were being assessed together. So it's important to keep in mind. So are these patients that have high double cycling, these might be associated with survival mortality. It makes it has a good rationale behind that, because we think about this breath stacking, okay? These two breaths and the tidal volume being stacked, and what would be the impact of this on lung injury, duration of mechanical ventilation, and as we observed, probably survival. So this is another way to look at. So not only the asynchrony index in general, but also these periods of time where we're going to have a higher incidence of asynchrony. So, okay, we know that there are several types of asynchrony. We know that they are important because they might result in direct or indirect harm to the patient, or even in some cases might be potential. So we need to do something. How do we manage it? We need something to correct or assess. So the gold standard to assess patient ventilator asynchrony are still measurements that we can assess directly the patient effort. So nowadays, we still talk about esophageal pressure because we can estimate the patient effort. We can definitely see it, or electrical activity of the diaphragm. That would be another gold standard for assessing patient ventilator asynchrony. Because again, these two tools, with them, I can see exactly when the patient is having an effort. I can see the magnitude of the effort, and then I can combine it with the ventilator waveforms the other ventilator waveforms that I have on the ventilator screen. So ideally, esophageal pressure or electrical activity of the diaphragm, electromyography, those would be techniques that are more precise to detect patient ventilator asynchrony. However, as I showed you when I was showing some types of asynchrony, we can have quite good information just assessing pressure and flow waveforms already, okay? As I show you, most of the time, we're going to be able to detect very important asynchronies. What we are studying right now is trying to combine these waveforms, the typical pressure and flow, with other forms of estimating patient effort. So, for example, this was one study in which we assessed the ability of healthcare professionals to correctly identify patient ventilator synchrony, just looking at pressure and flow. And then we combined with the visualization of the muscular pressure. So we could actually see the patient effort. And in this case, for example, we could see here clearly that in the first breath, there was no effort, but in the second one, we can see that in the middle of the inspiration, the patient started an effort, and then I had this double cycling, and we could classify this as a reverse triggering. So what we observed was that if we just look at patient pressure and flow, we may identify a significant amount of asynchrony, higher than 50% of them. But if we have additional measurement or an estimate of patient effort, we can increase this sensitivity of detection by healthcare professionals. So that's important. We need to look at the pressure and flow are very important, but if we can combine, if we can have more information, these may increase our ability to detect asynchrony. And today we are also having some so artificial intelligence is growing a lot. We have some softwares, we have some machine learning softwares that are being developed to detect asynchrony. So the thing may evolve as we go. And how we treat it. Okay, so we detect at the bedside most of the time, just using pressure and flow, and how we treat. And how we treat, guys, most of the time, I would say it's probably with effective adjustments in the ventilator. So here's an example as well in a study from Chile showing the asynchrony index in a baseline scenario and how it decreased when we optimized, for example, pressure support on inspiratory time. So those like the adjustments in the ventilator settings are very important. And when we compare this to increase in sedation, for example, it's even more effective. Okay, so we have here comparison of changing breath stack from the baseline. So if you don't do anything, it doesn't change. If you increase sedation, it changes because you're suppressing the patient effort. But if you do a correct adjustment in the ventilator, the reduce in patient ventilator asynchrony, it's even higher. So it's really important to think about the ventilator when we are thinking about, okay, how we manage this asynchrony. Having said that, we can forget, as I said, it's a very complex system. Okay, the human body, we have several organs and systems to think about. So even though setting the ventilator seems to be the best option most of the time, it won't be all the time. Okay, we have several factors being involved and we need to consider all of them when we manage patient-ventilator asynchrony. Okay, and I think this is the point where electrical impedance tomograph can help us a lot on the management of these asynchronous right now. So just a quick introduction for those that are not very familiar with electrical impedance tomograph or EIT. It's a non-invasive, radiation-free, real-time imaging technique where we can assess global and regional aeration of the lung at the bedside. So basically, we just have two belts around the thorax with 16 or 32 electrodes. We're going to have a small electrical current, and some of those electrodes will measure the resistance of the air. And what we could see, it's an image like this, where I can see the blue areas here, the air coming through the lungs. I can see this as a global, but I can also see in different regions of the lung, non-dependent, dependent, right, left, or as we decide. So it's a very nice technique. And we have, from electrical impedance tomography, we can collect a lot of variables. Some of them will need to be done like offline, so they are widely used for research, but a lot of them can be used online in real time at the bedside, and that's what I'm going to focus right now. So how can we use EIT to help us to manage patient ventilator asynchrony? So the first one, I'm going to start talking about EIT features in general that I think may help us. And the first one is the plethysmography. Okay, so with the plethysmography, we can have an accurate monitoring of the lung aeration. So when we were talking about this double cycling before, okay, so two breaths that are pretty close, and I ended up having like maybe with the double of the tidal volume. Look at what we can see here with the EIT. So the plethysmograph here is the waveforms that we can see here in the bottom. Now here we can see here on the top, and we can see here for each breath. So the change in each breath, that represents the tidal volume, okay? And we can see here in this breath, for example, we had this double triggering, and we can actually see that the patient didn't exhale completely, and we had another breath. So look at how dangerous potentially this type of asynchrony may be. If you are constantly giving this patient this high tidal volume. So with electrical impedance tomography, so as I said, it can offer us a very accurate monitoring for the lung aeration, and it may help us detect like early signs of lung overdistension. So if this is something that, okay, we have started seeing this right now, how often this is going to happen, it's something that we need to monitor. So just the monitoring of the airway, of the tidal volume, of the ventilation, it's way more precise here when I have electrical impedance tomography. And I can also see like visually to which regions I am going to. Okay, so I can see the visual representation of aeration, which areas are more potentially at risk of overdistension. And I can also see, as I said, as a global, what's going on with the tidal volume. Is this patient exhaling the tidal volume, or I'm just like increasing the aeration and the risk of overdistension? Another important variable that we can assess with electrical impedance tomography is the end expiratory lung impedance, which is a surrogate of end expiratory lung volume. Okay, so we can see, so as I said, the change in the delta Z, so this change in impedance over time, it represents the aeration. It correlates very well with tidal volume. And the volume at the end of the expiration, or the end expiratory lung impedance, it's a measurement that we can use here to help us to understand, okay, so what's going on? What's happening with the air at the end of the expiration? Is it being trapped? Are we recruiting some areas of the lung? are we de-recruiting some areas of the lung? So that's a good technique. So if you look at here, so now you can see, if you look at the plethysmograph here, we just reduce we just increase the duration of the period of that we are observing right now, and we can see a trend over time. Okay, we can see that the end expiratory lung impedance and potentially the end expiratory lung volume, it's increasing over time. So what's going on here? What's happening? And that's a really early detection too, because like we can also go to a trends screen that I'm going to show you in a minute, and we can combine different parameters to see what happened here. When did this end expiratory lung volume started increasing? When did I start having this air trapping, or was it just lung recruitment? What happened? Was it when I set something specifically in the ventilator? Was what happened at that time point? Was it when I changed the position of the patient and then the patient became more uncomfortable, and the expiratory lung volume started change? So the EIT offers us a more comprehensive assessment of several aspects that we can identify and potentially change and manage in our patient to improve patient outcome, to improve the ventilator management in general. This is another example, very interesting, that Professor Amato's group published last year in the Blue Journal. And they used the EIT to monitor the change in end expiratory lung impedance after the use of neuromuscular blocking agents, because this is a topic that it's a huge debate in the early phases of acute respiratory failure. Should we do neuromuscular blocking agents, yes or no? And they were trying to see what was happening with these patients, because they observed that for a couple of patients it increased. They started neuromuscular blockage in these patients, and the expiratory lung volume increased. So they did a study, an observational study to assess this over time, and they observed that in half of the patients, it did not change the end expiratory lung impedance. So it would be this panel B here. So you can see on the top the plethysmography, and in the bottom you can see the esophageal pressure. When we do the neuromuscular blockade, of course, the effort stops, but the end expiratory lung impedance doesn't change. It remains pretty much the same. However, in half of the patients, when they did the neuromuscular blockade, the end expiratory lung impedance increased, and they did several analyses, but they observed that this was associated with a strong expiratory effort at the end of the inspiration, or even during the whole the whole expiration, and this was potentially leading to lung collapse. So it was not good. So in this case, it might be beneficial to do neuromuscular blocking agents. So EIT can be a great technique, a great tool to also monitor the interventions that we do to see, okay, this is an intervention that we debate a lot about the benefits or the harms of doing neuromuscular blocking agents for these patients. And the EIT may help you to identify the effects there at the bedside in real time. And okay, for some patients, let's not do this. It will not improve anything. So we may need to go in another direction to change, to improve patient ventilator interaction. But for some patients, that may be a good solution. So that's what I said. Adjusting the ventilator most of the time is the best option, but it's not always. The human body is a very complex system. The other technique that we can use is the assessment of regional ventilation. So with EIT, as I said, we can have a good estimation of not only global aeration, but also regional aeration. So again, here I have some ventilator waveforms on the top, from top to bottom, flow, pressure, and tidal volume. And you can see here in a couple of graphs, a double cycling. Okay, so 2 breaths with expiratory time very short. And if you look at the ventilator screen, what we're gonna see is this one. So we have the first tidal volume increasing, and then the ventilator resets this value, and we have another tidal volume. If you look at this, it doesn't seem okay. That's not so harmful. It's just like two inspiratory, two tidal volumes, pretty close to each other. But then we look at the EIT and look at what actually happened, because the ventilator always reset the tidal volume here. But what is actually happening is that the patient is summing, so it didn't exhale that tidal volume, and the next tidal volume is the same one that you set, but when combined with the initial tidal volume, that we ended up with a really high tidal volume. So we can observe this with the global plethysmography, and as I said, but we can also look at this regionally. We have an asymmetrical type of lung injury so common in clinical practice. You have a patient with a pneumonia, with an infection in one lung, while the other is not so compromised. Like having an EIT would help to individualize the ventilation and prevent the injury to that specific point, okay, to that specific area. So the EIT will not only help you to identify asynchrony, but also individualize the treatment so you prevent the harm that we could generate with that type of asynchrony to that specific patient, looking at the specific response at that time point. Another thing that the regional ventilation may give us is also some insights on how is the respiratory muscle activity. So again, the same study of Professor Amato, where they assessed electrical impedance tomography and the change in not only in the expiratory lung impedance, but also regional ventilation after neuromuscular blocking agents. So what they observed is like in this, in a couple of patients, these patients that it did not change, for example, the end expiratory lung impedance. The change in the distribution of ventilation. So those patients that have like high inspiratory effort, so the diaphragm was really with a high contraction, the ventilation was predominantly dorsal. So this was a representative case. So you can see here 73% of the ventilation was being dorsal. And we have an inspiratory effort way higher than those patients that were non-responders, okay? And the distribution here of ventilation was way more even. So the regional distribution of the ventilation may also give you an idea on how is the activity of the respiratory muscles. I think it's a good technique. Of course, it's not a gold standard, but can give you some idea. Okay, is this patient using the diaphragm too much? That's why we are having a lot of dorsal ventilation. Or no, we may have a lot of dorsal collapse because the patient's not using the diaphragm at all. I think the EIT can give us some insights into the activity of the muscles that will help us to properly manage and assess the response of our interventions. Another measurement that we can use is we can estimate like Pendeluft. Not all EIT device will give you the precise Pendeluft volume and everything, but we can definitely see this uneven time constants. Okay, if we look at different zones, so one way to look at the EIT is divide the lung in 4 layers from non-dependent to dependent. And we could potentially see these delays and try to adjust the ventilator or see what's going on to prevent this type of mechanisms that we know that is associated with patient self-inflated lung injury. So that's another one. And now, just almost finalizing here, so we can take a look at some questions. TIMPEL has the last software, the Enlight 2100. has a really good um, tool combined with EIT. So now we can use all these variables, all these measurements to assess patient ventilator synchrony. But what the TIMPEL has right now, it also combines with an asynchrony assessment. So on the top of assessing global and regional lung volume and expiratory lung impedance, potential pendeluft, we can also actually automatically detect patient ventilator asynchrony. So we can see here, for example, there's right, like one type of asynchrony. The patient is having double triggering. Let me see. Let me wait for the next one. So yeah, so we can see here with this image, the software is going to detect the percentage of breaths and the number of breaths that are presenting, for example, double cycling, reverse triggering, breath stacking, all potentially very harmful types of asynchrony. So that's combined, is integrated with the latest software. As I said, we can export, so we can have all this data now in a trend screen. So we can see over time, we can look at specifically. So here we are combining, for example, in the middle, like in the middle plot here, we can see the reverse triggering, the incidence of reverse triggering. We can go back to the trends and look at what exactly, what happened here and which time we started having reverse triggering. And we can combine with other ventilator settings that are monitored by the EIT, because TIMPO, for example, is also continuously capturing airway pressure and flow. So we can see what changed at that time point that resulted in a cluster of reverse triggering or, for example, breath stacking here. So we can also see when it's potentially harmful, right? So we have here the reverse triggering. As I said, not always reverse triggering will cause breath stacking. I think when it causes breath stacking is when it's more dangerous. And the TIMPO will give you a lot of outputs, summaries that will help you managing the patient. This is an example of a patient, for example, that was being ventilated with 7 ml per kilogram, and we tried to decrease to 6 ml per kilogram, but then when we increase, we observe a higher increase in double triggering and breath stacking. So we can identify, okay, so when we reduce the tidal volume, let's do something, let's see what other variables we could potentially do to manage these patients. So I know that is a lot of information. I think it's just like food for you to think about. Okay, so what I really want you to bring with you at the end of this presentation is that patient ventilator asynchrony is really common in clinical practice, and it can lead in both directions. Like it can bring direct and indirect negative effects. However, some types of asynchrony may not necessarily be harmful. In fact, some of them may reflect that the respiratory drive is preserved or the adaptive mechanisms are working well in the patient. And in this context, I think the EIT, it's an innovative technology that offers real-time, non-invasive functional assessment that will support our understanding of patient-ventilator interaction, and it will help us to distinguish which types of asynchrony are harmful and which types of asynchrony are potentially beneficial for the patients. That's it. We are currently doing one survey on patient ventilator asynchrony. So I invite whoever is interested in learning a little bit more about asynchrony to join us. And I also would like to invite anyone that is interested in electrical impedance tomography in patient ventilator asynchrony to reach out to me. I would be happy. We are accepting new members of the team for our team, but we can also do collaboration. So I would like to just leave my contact and I'll be happy to talk to everyone. Thank you, Glazy. I think we have some time for a couple of questions.
Mayson, thank you very much. Was brilliant. Thank you. Your lecture was really, really nice. And yes, we have some questions for discuss. And one is, in your clinical experience, how often do you observe pendeluft during patient ventilator asynchrony? And there is some type of asynchrony that are most commonly associated with pendeluft?
That's a tough question because the problem is that nowadays, like to assess, I would need an EIT, at the time point. I can look at the patient and think about how is the synchrony between thorax and abdomen and have some oh, this patient might be having pendeluft. How I can look at the X-ray, I can look at the CT, see if the distribution of injury is very heterogeneous. If this patient has a high effort, and I can make some inference to say this patient is probably having pendeluft, but it's just my thought. To measure, like we would need something like EIT. So we would need EIT to actually see and observe these delays, because what we have in the pendeluft is different time constants of different regions of the lung. And with the EIT at the bedside, it's the only way that we can see, okay, this region is being inflated first and the air is going through another one. So if I say how many patients, it's going to be biased by how many patients I have EIT right now. So because I come from an ICU, I used to work in the ICU with Professor Marcelo Amato, and we used EIT for a lot of patients. I would say that it's quite common when we have patients with high effort, definite common. But again, we need to spread it a little bit more and see in which scenarios this is more prevalent, and EIT is definitely what we have right now to really quantify at the bedside. I see.
Yeah. No, this is great, because also important to quantify how is the size of the
Yeah,
pen
exactly. Yeah.
itself.
It's so that's why I think EIT is so important. I think that's the point. EIT is gonna help us identify, because it gives us such a good measurement of lung mechanics, global and regional. We talk a lot about regional mechanics today, because we cannot just look at the whole thing. It's not just the global compliance, but also how is the distribution of lung injury, and EIT is definitely what's gonna help us.
Perfect. We have plenty of questions for you. So again, your talk was amazing. And there is you talk about a reverse trigger, double trigger. There is any other type that can be automatically detected by EIT? Any other type of
EIT.
synchrony?
So right now, the software we are right now only like breath stacking, double triggering, and reverse triggering. You can help me with that. I can see you are like
you are right, and I think you also talk about that. These are the most dangerous asynchrony.
Yeah,
So
exactly.
I guess this is the goal, to see which one is the most dangerous and then help you.
Yeah, because having this breath stacking, it's potential. It's what we have been fighting in the past decades. Let's reduce this lung stretch and lung strain, right? And then we come here, okay, let's reduce tidal volume, let's reduce plateau pressure, let's reduce driving pressure, and then we have this double cycling all the time, this breath stacking. So we think that we are reducing driving pressure over time, but actually when we have the breath stacking, then the driving pressure will go way more than what we expected. So that's why I think those two are potentially the most harmful types of asynchrony. And
Perfect. In your experience, is there a connection between undetected asynchrony and poor outcomes, like lung injury, delay weaning, or long-term diaphragm weakness?
Yeah, I do think so. Yeah, I would say, because we don't look at this continuously. And I would say in both directions, there is an association with worse outcomes, but I also think there's, as I said, I do believe that a couple of asynchronies are beneficial, and and might just be a signal that the patient is awaking. This, for example, it's a wasted effort, small, it's not causing any like higher stress in the lung or something like that. Uh, and that we are missing, and is something that will say, oh, this patient's good, like is start breathing. Like the patients, for example, is start like to have reverse triggering initial. And maybe sometimes it just indicates that the patient is awake and you should change it to pressure support and let the patient breathe. So in this case, it's a good signal and we missed it. Okay, because we were not actively looking at reverse triggering. So the patients start like breathing and we could have change it to pressure support earlier and having this patient potentially weaned earlier. So it may go in both directions. And definitely also we missed a lot of breath stacking and double cycling that may cause lung injury. So I think both missed types of asynchrony can impact outcomes. So we really need to look at it.
Yeah, as at all.
Yeah.
And going this direction, there is also another question asking if you think treating isolated asynchrony events, like some occasional double trigger, is enough, or we should look at how the patterns happen over time. You present about the clusters, so what is your opinion?
I think that's a great question. And I don't have the answer right now. That's definitely because one thing that I think it's really important, like we are human beings, okay? We are not talking about a machine. So it's not something that happens all the time. So asynchrony is going to happen the same way all the time for all of them. I think the variability, and I was discussing this with a friend a couple of days ago, exactly. I think the variability is a key point for us to understand what's going to be the impact. Okay, so how much asynchrony is the patient doing? Is there any pattern? Is the patient that is evolving with more asynchrony over time, that having more clusters over time is something that you are doing in your clinical practice? So the way you position the patient constantly, and every time you position the patient that way, you start having like more asynchrony, and this is affecting that specific type of patient. Or is the condition, the patient condition, something in the brain? It's a patient that has like, or any drug that you're using that's impacting the variability of asynchrony. So I think I don't know the answer. I don't know. That's my question, but I think that's a really good, important topic to have a more wide, more broad assessment of asynchrony to try to identify patterns and everything, like how it evolves over time, the variability of asynchrony within a patient. I think that's really important, and it's definitely not something that we have the answer for.
Yeah, no, this is great. And going also in this direction, you mentioned in your last slides that not every time asynchrony is bad. So there is a question asking if there in your clinical practice there is any type of asynchrony that you, when you see, you permiss. There is some permissive asynchrony.
Yeah, I would say initially. So reverse triggering, it's one type. It's almost like it's not that I'm gonna allow this type of asynchrony to happen continuously, but it's more like what I want to say is that it's a good sign. So you see the patient, you reduce the sedation, the patient starts breathing, you start having some reverse triggering. That might be a good sign. It doesn't mean that I'm going to keep the patient there, like doing reverse triggering for all the time. So think with me like that, okay? So it's not we want to keep the patient asynchronous, but it's a good sign for me to look at that and say, okay, let me assess the intrinsic respiratory rate to see if the patient actually is having efforts over time, and I can change to pressure support. So in this scenario, that might be good. Okay, so that's more the idea. Or okay, we have this asynchrony. That's a good sign. Let's do something to improve the patient. It's not like, oh, I need to do, because we usually think, oh, we need to go back with that. The patient's not comfortable. Let's increase the pressure. Let's offer more tidal volume. Let's increase the respiratory. No, sometimes it's a good sign. You go back in terms of support.
Thank you. And the last question, there are plenty more, but I also suggest people to reach you via email. But do you think EIT could help us to go from reactive to protective management of asynchrony by detecting early patterns before they escalate?
Yeah, absolutely. I think that's two key points. Like it's the early detection, as they just mentioned, absolutely, because we can see in real time, we can see these trends over time. And I think what's really good with EIT, I can combine, as I showed the trend too, I can combine with different two, because right now, what I think we need to better understand asynchrony, it's a more comprehensive approach. And that's why I think EIT is so important, because we are getting there. It's not that we are there, okay, EIT is the solution for everything. No, but we are getting there. We have more information now. And the TIMPEL software, for example, combine now the asynchrony detection with the amazing global and regional ventilation assessment. So we are combining more things. So I think that's the point. So EIT can definitely help us to early detect what's going on, like to do a cause root analysis to see what happened here. When did I start like having this decreasing in the expiratory lung volume? When the ventilation changed too much to dorsal? When did that happen? So early detection is key. And also to see, okay, this patient is having this double trigger, is having this reverse triggering. Is this causing any overdistension at some point? What's going on? Can I allow this for a certain period and see how the patient goes? Can I reduce the sedation a little bit more? Because it's not cause any breath stacking. It's just the patient maybe starts waking. I tried to change to pressure support. It didn't work. Okay, let's try to reduce the sedation a little bit more, because it's not cause any injury, apparently injured to the lung. It's not causing breath stacking. So the EIT can help us with us. Okay, is this asynchrony being harmful? Can I tolerate a little bit until I do something, or do I need to do something right now, because right now the patient it's having double the tidal volume?
Yeah. No, this is Mayson. It's amazing. Terrific talk.
Yeah.
It was really, really brilliant.
Mm-hmm.
Thank you a lot. We have a lot of questions, but unfortunately we don't have time.
Please send them by email. I'll be happy to reply to all of them.
Yes. And thank you everyone who joined. This webinar was really fantastic. And we hope we can see again in the next webinar. So keep posting the TIMPEL social media, because we are going to post there for the next session. And Mayson, thank you again. Thank you very much. Thank you, everyone.
Thank you, everyone. Yeah.